Well, thank you for joining us. We are here today with Dr. Iacobelli. He has had over 35 years placing implants, so we're very lucky to have him. And what we're going to be discussing is a magic core flapless placement of an implant to replace tooth number 20. It's been pre-extracted. And the way that we're going to do this is we have a video. It's about 3 minutes and 20 seconds long. And what we're going to do is we're going to play the entire video just so we can watch the entire length, the overall procedure, have Dr. Iacobelli make comments as we're going through this. And then we're going to go back and we're going to slowly dissect each part of the technique. And I think when we go back the second time, what I would like to do is discuss a little bit about the design of the implant itself, because the design of the implant really affects the technique that we use to place it, and it'll kind of tie everything together so you have a better understanding. So what I'd like to do first is we'll go back and we'll play the entire video, just nonstop, full length, 3 minutes and 20 seconds worth. Dr. Iacobelli, I invite you to make your comments as we're watching this video, and then we'll go back and kind of talk about all the little nuances of the technique. So I'm going to go back to the video. I'm going to share that on our screen. And here we go. Let me make it full screen. There we go.
Yeah, so don't forget, Dr. Kim did this procedure. I want you to take a good look at that band of attached gingiva. And also, Mike, for sake of saving our own breath, I'm very okay with everybody addressing me as Mark here. That'll keep it easy. Right.
Mark and Mike.
You got it. So that palpation, that's assessment of the ridge. Notice, key point, no flap. Each of these little parts, these little steps, there's specific reasons which we'll discuss. Assessment of the tissue around that guide pin. That guide pin itself is ideally going to be the center point of the implant major body. Very interesting thing here going on is they're making the osteotomy, what they would call body preparation. Notice how the drill fit right over that little pin. That's part of the tripartite benefit of using the IBS implant. Checking for the bone removal, making sure it's appropriate depth. Very, very, very specific instrumentation here. This is now the fine threading preparation, fine preparation, thin thread preparation with the tap drill. Backing out. And now, probably the most unprecedented thing, notice at the top of your screen, that implant is getting threaded in with finger pressure. Only there, when it's just being snugged down the last millimeter or two, is the torque wrench applied to it. Stability, immobility being verified. There it is when it's all completed. Notice how the implant mirrors that guide pin placement. We'll also talk about the healing of the soft tissue when we start to dissect this video.
Yeah, that was great. Let me go back. So maybe we talk about this, just that as we watch this technique, We have the Academy of Minimally Invasive Implantology, which Dr. Mark, you referred to as just being able to do this with as a flapless procedure. I know a lot of doctors that either place implants currently always lay a flap, and those that are concerned about starting to get into implants are concerned about how to lay the flap. And with this system, we kind of allay those fears because we've bypassed the flap, which is a little different, which affects how we are going to explain this procedure. As I mentioned during the introduction, before we have Dr. Mark kind of go through all this, is that the implant itself is unique in its design. We have these, they're called magic fin threading in the body of the implant. And then we have the abutment portion above that, and it's all one part. And the very top part of it is the abutment, basically. We have the 2 millimeter ferrule at the very top. But between that and where the fins are, we have what's called the cuff. And it's that magic cuff area that is kind of the magic of this system. And we'll go through and we'll talk a little bit more about that. But I think it's important for the viewers to understand that this is a one body type implant system where we have the threads and we have the abutment, and like you would with any other system. But this cuff that we have right here in the middle is really what makes this very unique. So I just want to explain that before we go into the rest of the video.
Yeah, so Mike, even prior to advancing this at all, you're in control of the cursor, which is fine.
Yes.
So when you're looking at the black part of that implant, that is the area of the implant that has the surface roughened for ideal integration there. Notice how thin those fin threads are. But as you look at the major body of the implant, not including the fin threads, this one-piece implant is tapered in nature. And you're going to notice when we do the osteotomy drilling, okay, that the shape of the osteotomy burr is hollow, but it follows that exact taper of the major body. And then when the fine preparation, or tapping as some people would know it, that's when the fin threads are cut. So Mike, if you put the cursor at the very base of that implant, you're going to see way down below where it first would enter the bone. You're going to go down there, yep, and that is not self-tapping. That is not self-advancing. It's not cutting in any way. So the base of the osteotomy, you're going to see, needs to be prepared, or possibly even over-prepared by a hair, which the Dr. Kim does in the video. So this can seat without pressure. Okay? Yes. The last important thing is when you go up to the magic cuff, that highly polished area, that area, because of the way it's machine polished, can be adaptive to being partially in bone. It can be adaptive to the soft tissue around it, but appreciate that we're using the burr, the hollow trephine burr, the magic burr, if you will, to pierce through the tissue, and the shape of that burr is going to mean the minimal damage to the tissue, so that the initial cuff of tissue formed around the magic cuff, that keratinized tissue will be firmly adapted to it when it's seated into place. Mm-hmm. That's what allows for the lack of sutures and the tight fit that eventually will allow for the keratinized tissue to develop and actually overdevelop as needed to help cover the cuff. So those are the fine details that we'll try to highlight how the technique, the instrumentation, and the implant all fit together with this.
Yeah, those are all great points. Thank you. All right, so just to kind of emphasize that this was done by Dr. Kim, and we're just going to narrate it and look at the technique that Dr. Kim had. We have a male 46 missing a tooth, something that we would see in our own practices every day. So as we go through this, we'll look at the preoperative Panorex just to show us that's pre-extracted.
Stop it right. Oh, if you want to stop it there in the Panorex real quick.
Yep. And go back.
Perfect. So some of us might look at that and say, you know, that tooth was probably periodontally involved. The trabeculation in that bone is not real healed, if you will, postoperatively. And some folks might be a little skittish about placing an implant into that area due to density of the bone. With the Magic Core implant and that thin thread, I'm not going to be too concerned about that because stability is going to be high for a procedure like this. So on the distal portion of where that implant's going to go, it's far more trabeculated, probably far denser, whereas on the mesial portion, it is not. Okay? Go ahead, Mike. Stop it there again. Now notice here, because we're doing this flapless, we're attentive to the fact that there is an adequate amount of attached gingiva or keratinized tissue around that potential implant site. Just like a natural tooth, we would like to have, in the end result, 2 to 3 millimeters of attached gingiva, buccally and lingually, to help protect the margin of where that crown is going to be sitting on the implant. And certainly this site provides that. Go ahead. Again, stop it. Stop it there. Perfect. So you could see the mirror was wiggling there on the right. That's to be certain that right above the word mobility, where that tissue is not mobile, okay? Even though there's times when we get faked out that there could be keratinized tissue or possibly non-keratinized tissue, the key point is lack of tissue mobility. That's the part that we want to highlight with this, okay? So we're not seeing that tissue move, and as long as that tissue isn't moving, we know that the ability to form keratinized-like tissue, even if it's not present in the amounts we want, will in fact occur because the tissue is not mobile. The perio probe is simply getting a depth marking on how deep that is, and establishment of where the center point of the major body of the implant would be. You're going to notice that in the next picture, or in the next few frames, that the operator, Dr. Kim, his glove is going to get in the way because he is going to eventually want to palpate where the lingual tissue is. This magic split is being used because the evaluation of the cortical bone over the top of the implant site is being evaluated. Notice with the hand pressure, it's not advancing much past where the attached gingiva is and the thickness. So now one can assume that that cortical bone is hard and that we'll need to make an osteotomy into it. Here comes his fingers to evaluate the trajectory of the bone, which will then be mimicked with the trajectory of his guide pin drilling. This is that 3D thing, Mike, that every dentist had to pass before they got into dental school, right?
Yeah, I think that's a great point to bring up, is that, this system, it's flapless, so we're feeling for where the bone is, the hard tissue underneath the soft tissue. It would be ideal to have a cone beam, CT at this point, but there's no surgical guide.
Surgical guides with this in my hands typically are not needed. So he's palpating where that lingual undercut would be, right? Mm-hmm. And now he's mimicking that trajectory of this guide pin. So this guide pin drill is going at least 5 millimeters in. Now it's in past the tissue and it's going in 3 or 4 millimeters into the bone. So you're going to see him as he buries it up to the neck of that drill. Okay. Straight in, ideally straight out.
Yeah.
Don't want to go up and down. And then the guide pin is placed into it, pushing the tissue out of the way, Sometimes it needs to be tapped a little bit or pushed in with your thumb, like he's doing there, checking for stability. All right, now is when you're going to get your CT. And this CT, if you could stop it there, Mike,
Yep.
you could see toward the lingual surface, there's not a big lingual undercut here. And with the palpation that Dr. Kim did, he has hit that spot smack dab in the center where he wants to be. Okay, so that's really good. Now from this sagittal cut on the CT scan, the operator is 100% able to take some measurements and determine exactly what size implant is going to be placed, which will be optimal for this specific site. Okay, so you're noticing the length is being determined. He's 11.4. He's going to sit down on some trabeculated bone, well superior to the inferior alveolar canal, and there's 6.5 millimeters buccal to lingual of that cortical plate. Now, a very interesting point with the Magic Core implant is that a 6.5 millimeter site with a typical implant system would mandate that you would want to have 1.5 to 2 millimeters on the buccal, 1.5 to 2 millimeters on the lingual. So that means you'd be putting in a 3.5 millimeter wide implant on the occlusal surface to allow to have that bone on the buccal and lingual. Or you would need to reduce that occlusal bone and then get a wider implant, but that would necessitate what? A flap, be more invasive, not in keeping with AMI techniques. The key point with this is that with the Magic Core implant, you can have far less bone buccally and lingually because we're not damaging the bone. You don't have the osteoclastic, osteoblastic activity. Therefore, you don't have the dieback around the threads that everybody's so deathly afraid of. That does not occur with this implant. We'll compare this view to the final view with the implant in place to see how that plays out.
Yeah, great points.
So now that cuff height, that magic cuff height, is being determined. So the operator is going around 4 different spots around that guide pin, and they're measuring the tissue depth. The thickest tissue depth then becomes the cuff height, the magic cuff height. In the posterior, that cuff should be right below the level of the gingiva. In the anterior, we try to keep it 1 millimeter below the gingiva. Now, stop, oh, Mike, that is perfect. How did you do that? Notice, all right, you got great hands. That's probably why you're a dentist, right?
That's right.
So notice that guide pin and the peripheral bone removal drill, or PBR drill, is made to specifically go right over the top of that drill. And when this drill goes in, it's going to go through the soft tissue and no more than 4 millimeters into bone. So as you're looking at the hash marks on that burr, the bottom of the hash mark toward the occlusal surface of where he's going to be drilling, that's 3 millimeters, then 5 millimeters, then 7 millimeters. Okay, so the tissue depth, I believe, was 3. So that tissue depth is going to go 3 into the first line, and then you're going to see the operator stop between the 2 black marks in there somewhere to remove the pin. When he removes that PBR drill, that guide pin is going to be buried within inside of it. Keeping the trajectory. There he is between those 2 marks. Right there. Coming back out. And buried within that trephine burr, you could see the blue shining right there through it. It's removing the tissue, the bone, and the guide pin, all in one fell swoop. You don't want to go all the way down to depth, because you will never, well, I can't say never, but you will have a difficult time removing the bone, the guide pin, and the tissue if you drive it all the way up into that burr.
Yep.
So that's been removed. Now they're placing the PBR drill back in and driving it down to depth. That depth is 11 millimeters right there. So 4, I believe, or 4 right there, 11. Now he's going a little bit further. Ideally going to go down to 13. 13 minus the 3, that would get us to about 10. So we're going to see that the fixture will probably end up being an 11 millimeter fixture. There's the bone core.
Nice core bone there, huh?
Yeah, I mean, that's the gold standard. That autogenous bone is what you want. Now, if when the operator goes in, they feel that there is too much bone marrow space, meaning the trabecular bone is not dense enough and it's real hollow, that's the bone that you could pack into that empty site, and that'll help spur on a quicker healing process by building more bone. Of course, it'll be first woven bone, then eventually laminar bone around the body of that implant. And guess what? You don't have to open up a bottle of bone or anything like that. That's there for the taking. It is like perfect for this situation.
So Mark, maybe you can make a comment, because this burr, this is a great angle, I think, because you can see the bone has gone into our drill right here. Yeah. But when you look at this, how does this differ from your regular twist drill versus what we're using right here? And how does it feel? Does it slip around on the bone as much, getting started maybe on a thinner ridge? What are your experiences with this drill?
Well, there's really 3 parts of this drill, okay? First thing, if you kind of notice from the shape of it, like down at the base of it, well, yeah, down there at the base, that's the same width as the major body at the base of the tapered implant. And you'll see how it gets wider as you go to the top, and that's to accommodate that magic cuff width, okay, the abutment width. That's the first thing. Second thing, this is a hollow trephine burr, so the cutting edge is just at the tip of that burr. Now, that burr will have chatter just like any other burr, except for the fact that this burr being hollow and trephine, it's made to rotate at 2,000 RPMs. That is totally against everything one would learn with typical implant systems. Usually just the pilot drill runs at a high RPM, and then you're down under 1,000 RPMs because they don't want to increase the heat delivered to the bone by the friction of the burr, the twist drill going through it. By this being end cutting and having the trephine portion, it disperses the heat, and it's made to run at 2,000 RPMs. So just like you get chatter with the low speed handpiece, no chatter with the high speed handpiece, this is functioning at a high revolutions per minute, so chatter is minimal, absolute minimal. And then the bone core is able to be harvested from the inside. So it's cooled, it's sharp, it's made to travel at 2,000 RPMs, and it gives you the best of both worlds. And this angle is actually quite significant. Dr. Kim was an expert in getting the trajectory of that guide pin in perfectly, but if one needed to change the trajectory, it would be very possible just by using the side of those cutting serrations on the end of the burr to take in, and you could actually feather drill or side cut that just a slight bit to change the trajectory. You would never, ever, ever be able to do that with a typical twist drill, as most implantologists would know it. So yes, you have to be a little more spot on because it's a one drill system. You'll see that this is it. Only thing we have to do now is flatten out the bottom. From there, it's make the fin thread. So right there, they're checking out the removal of that bony core. Sometimes it comes out in its entirety. Most times it leaves a little nub on the bottom. And for that, they have a specific drill to get rid of that nub. So there they're checking. Here is also where they can decide, do they need to use that harvested bone to fill the bone marrow. Here comes the end cutting burr, final depth drill, and that they're going to go to 13, which is 3 in the tissue, 11 for the body, and maybe even a pinch more. That pinch more and just kind of guarantees that you don't have to over torque the implant. Okay. Now here is where they can put the drill path, magic tap drill path indicator. That determines, don't go too fast here, brother. This determines the pathway by which you want to do the fine drill threading, because there is not a lot of trabecular bone inside there, meaning this is probably D1 or 2 on the surface, but D3 or 4 in the body of where that medullary bone is. There is no tap drill guide left in the site. And now the operator is mimicking that trajectory, and at a very slow rate of speed, 20 RPMs, they're cutting the threads for the magic fins to go into. Notice the tissue thickness here, they're saying is 2 plus 5 millimeters of tapping, so these going down to 7 millimeters. Now, despite the fact that they're putting in a long implant, they're only tapping the first part of it because the medullary bone is very soft underneath. Okay. If it was hard D1 bone, there would be a pin guide left in there, and you would go all to within the last 2 millimeters of the overall major body length in your tapping. But because this bone is so soft, that's not being done.
Yeah, I think I just want to so the viewers can see how, again, this is a burr, and it is cutting the threads into the bone that match that of the implant body, the magic threads that are on the body.
Perfect. Here comes the implant, same trajectory. Notice it's on a hand driver here. It's a 9 millimeter implant with a 5.5 millimeter abutment. All of that depth is being achieved by just finger pressure. Truth is, in my hands, I usually get just about 80% of the implant in 80% of the time, just by hand. That's an antithesis as well, because we're used to cranking it in as tight as we can get it. With this system, you'll begin to realize that torque value and stability are not related. In fact, too much torque crushes the bone and ends up working against us in the healing process. So now the cover screw is being placed after they're checking for that stability, and appreciate the fact that there's still some attached gingiva there for that to grow, and watch how that band of attached gingiva is actually going to increase from November when the crown was seated to March when the final x-ray was taken. That's initially. Now let's take a look 4 months later, I think what would be. You can see how that trajectory is mimicked, and notice how thin the bone is toward the neck, the top of the implant. No fears there, because we didn't crush the bone by over torquing it. Now as that kind of slowly goes out to the finish, you can see how there's more attached gingiva there. That tissue on growth occurs. The crown actually appears a little bit shorter a few months out. And notice how we've had no dieback of the bone. None. 0. And that's typical. We could take a scan of this in another 12 months and you'll see that bone won't move. At least in my hands, I haven't seen that with any of the cases I've placed like that. Whereas you can fall back on your implant education, and usually we lose a millimeter of bone within the first 6 to 12 months. That's the beauty of the AMI technique. That patient had that implant placed, no sutures, no incision, and great restoration.
Yeah, it's the, I think that's one of the big differences is that threading that we showed allowed the implant to go into the bone and engage it without crushing it, like Mark, as you're saying. And so we have a lot less osteoclastic activity once the placement's done, so we can have the thinner bone there, just to kind of clarify that, because it was a great point that you made. And we get very little dieback, if any at all, probably very minimal, and that tissue just climbs up that cuff and gives us that nice finished result like we saw. So we saw when the crown initially went down that there was maybe a little bit of gray down there at the margin, and then a few months later that tissue just grew up, as you were talking about, because of that magic cuff design that we alluded to as we got into the dissection of that video.
Yeah. You know, in my hands, Mike, I think at the end of that video, instead of putting the healing cap in place, I may have considered putting a healing collar in place. And with that, I tend to get the tissue formation a little bit quicker. And it's straight up out of the gate. You know, in Cleveland, Ohio, where I'm from, a lot of my patients, even if they have a metallic tooth on the one behind it, they see any hint of that little gray margin and they're starting to freak out, you know? So yeah, if I can get a little jump start on that tissue on growth and make sure that my ceramo-metal margin is tucked nicely below the gingiva, just makes for a happier patient and keeps some of these gray hairs to a minimum, you know?
Yeah. Hey, you know, you've got a lot of experience with the Magic Horse system and just implants in general. Placing an implant like this, as we mentioned, it's a one body, so we don't have to go back in there and do an uncovering and disrupt the soft tissue healing that's occurred. How do you see that as impacting the restorative time, or the time from the surgery to the time that you would feel comfortable restoring this? Does it shorten it? Does it make it easier to predict, or what have your experiences been?
You know, it does shorten the healing time because, in my opinion, I'm not waiting for that soft tissue to mature. Okay. I think the physiology of the bone is the physiology of the bone. I mean, we can't really change Mother Nature and how that osteoclastic, how that osteoblastic healing curve progresses, but we can decrease the downward slope of that osteoclastic activity so it kind of gets on that increased slope with osteoblastic activity quicker by having less bone death. Okay. When you think about it microscopically, when you're using a twist drill instead of a trephine drill, especially when you're doing sequential drilling, you're taking that bone and you're crushing, pulverizing, as Hank Pond says, you know, you're making bone soup in there, man. And that bone soup is highly dependent upon the osteoclastic activity and then building it up with osteoblasts afterwards. With this, you're not doing that. So while you still need Mother Nature to lay down that new bone, it happens far more quickly. In addition, I'm not waiting for the soft tissue to remodel and remold itself. What it looks like in this picture right here is exactly what it's going to look like in 3 months, maybe even 10 weeks when I go to restore it. This one, I would probably leave 3 months just because we know that medullary bone was lacking in comparison to maybe a typical D2 site.
Mm-hmm. So according to the osteoclast, you want to flatten out the curve, I guess, huh?
Yeah, that does seem to be the word.
Ironic.
Of the, isn't it?
So I think you did a great job going through this and analyzing. You made great points at every step of the way. Every time I hear you speak, I learn something too. So I just wanted to thank Dr. Iacobelli for going through this video with us. And we hope to see you for more of these types of programs as we look at different surgery tips and pointers you have to offer us. Thank you very much.
I would graciously accept that invitation.
That'd be great. Thank you.